Hello friends, this is a case of laparoscopic cholecystectomy and we will perform it by fundus first method. So let us see skin to skin how to perform fundus first cholecystectomy. This is a simple cholecystectomy, but we should learn how to do fundus first because it is very important for the Mirigy syndrome or for the very short cystic duct or for the frozen Calot strangle. So here suction irrigation and hanging drop test is done just to make it sure that our varus needle is inside the abdomen. And now we are connecting the insufflator and the insufflation will start. So this is 22-year-old female with having multiple gallstone and we are introducing the varus needle through the inferior crease of umbilicus. And in the fundus first cholecystectomy, port will be same. You can use 4 port, one in the inferior crease of umbilicus, another epigastric, third mid clavicular line just below the costal margin, and the fourth anterior axillary line at the level of umbilicus. But we will not use fundus retractor, rather than we have to use Nathanson lever retractor to push the lever towards the right shoulder, and with the grasper we have to pull the gallbladder down. In the antegrade cholecystectomy, fundus of the gallbladder itself act as a lever retractor, but in retrograde cholecystectomy, you have to pull the fundus down and you have to push the lever towards the diaphragm. So, for that you can use fan retractor or Nathanson lever retractor. Nathanson lever retractor is of two type, one is handheld and another is table held. So, here we will use table handheld Nathanson lever retractor. Many people also they say that it is a snake retractor. So, now we can see varus needle insufflation is over, and after that we will enlarge the incision to 11 mm and then we will put the first port. So, this is a smiling incision 11 mm and this is the first port, and now it is in. After that, this is the second port that is just below the Jiffy sternum. This is also 10 mm. However, you can use here 5 mm also. In this one thing I did not say that we will use Mishra's knot, we will not use the clip, and that is one of the best knot. In the fundus first cholecystectomy, extracorporeal slip knot is the best knot because it does not have a risk of lateral clipping of the CBD, because slip knot has an advantage that by default it slips to the junction. It cannot take the tented CVD. The clip can take tented CVD wherever you will apply. Titanium clip is metal, that will do, but knot is the best for fundus first cholecystectomy. So, here we will use Mishra's knot. You may use Rodder's knot or endo loop. Here you can see little bit gallbladder was intrahepatic. So, here it is the traction is given and this little bit fundus part of the intrahepatic gallbladder we are separating, and the purpose is that we should have some space, then you can use the retractor to lift the lever towards the diaphragm. So, slowly after cutting the peritoneum bluntly, you can separate the lever from the fundus of the gallbladder, and this part of the fundus was little bit intrahepatic, it was not projected beyond the margin. So, you have to be careful, otherwise there may be the puncture of the gallbladder. So, this is slowly separating from the fundus, and harmonic always if you are using, keep the Teflon jaw towards the gallbladder so that it will not rupture, and with the vibrating jaw you can give anterior traction if you want, and then only, otherwise it will puncture the gallbladder. So, you can see this part of the fundus was little bit intrahepatic, otherwise it will be very easy to perform. However, this is also not difficult, this part you have to be little careful, so that, and always hook, look and then cook, and always anterior traction should be given. And now this intrahepatic gallbladder of the fundus part is safely separated, and cordial traction is given over the fundus. In cases of antegrade cholecystectomy, you are pushing the gallbladder towards the right shoulder, but in fundus first you have to put it down. Here we are using little bit adhesiolysis, these are the adhesions, however these are flimsy adhesions. So, for the time being we are just lifting the fundus of the gallbladder and doing little bit adhesiolysis. Right now we have not done, till now we have not brought the this liver retractor, because at this point the gallbladder itself is acting as a liver retractor, only fundus part was separated, and we can see little bit duodenum is also hooked up with the adhesions with the gallbladder. So, those adhesions easily you can separate with the harmonic or hook or scissors, but take care that when you are separating, a stripping technique should be used and you can strip it down. So, these adhesions are slowly separating. You can see this is the part of the duodenum which was hooked up, and that also is stripping down, and we should try to avoid energy near the duodenum. So, it is already stripped and we have reached up to the cystic pedicle. Now, again fundus first will start. However, this was a simple case, even the antegrade was also possible to do very nicely, but let us see how to do retrograde. In the retrograde, always take care that white areolar tissue plane should be maintained. Always remember, in laparoscopy white is right, and if you have a white areolar tissue plane, then gallbladder will also not puncture and the liver also will not bleed. So, this is a good areolar plane, and slowly it is getting separated. And once you are separating, you should take care that you should avoid excessive traction and you should avoid touching the lever. Now, it is enough, and you can use the Nathanson lever retractor now to retract, and little bit space is already there, and slowly you can separate it. During that separation, you have to be careful that enteromedial and enterolateral traction is not required here. However, inferomedial and inferolateral traction is required in the fundus first, and take care that this Nathanson lever retractor convex edge should push the lever, and once you have a sufficient space, then the flat surface should push the lever, and then there will be no injury to the lever. So, you can see now this is the convex edge which is pushing the lever, and now this is the inferomedial and inferolateral traction, and we are reaching now up to the neck of the gallbladder, it is reached, and then we should take care that once you reach to the lower part, then you should be careful that if the Rouvier sulcus is visible, then remain above the Rouvier sulcus, or if it is not present, which is there in the many cases, in those situations also, once you reach to the hepatobiliary triangle and cystic plate, you should stop. In this patient, we have already put the ICG. So, now we can see we are reaching up to down there, and this is the last part near the cystic pedicle, and it is stopped. After that, we will just turn the ICG mode on, and we will check that CBD, common hepatic duct and the cystic duct all is clearly visible. So, this is the ICG mode. You can see cystic duct is clearly visible and CBD is clearly visible, and common hepatic duct is also clearly visible. So, you can see this is the cystic duct and above is the common hepatic duct, and below on the right corner, and this is contrast mode of the ICG, that also is clearly showing the cystic duct here, and this is the angle between the cystic duct, common hepatic duct, and now we are taking the artery with the harmonic. This is again ICG mode in which cystic duct is clearly visible. So, you do not have a worry about that accidentally you will damage the cystic duct, and this artery will be now taken. So, this is the escultinization of the cystic duct, and little bit peritoneum of the over the cystic duct is separated, and now it is escultinized. Below is the CBD, and this is the artery. And now just keeping the Teflon jaw towards the duct, we will coagulate the artery. So, as you know, in harmonic, Teflon jaw does not allow energy to go to the duct. So, here Teflon jaw is touching the duct and artery is coagulating. This is the artery, and artery we have coagulated. However, if you want, you can clip also, or you can tie a knot also. So, here artery is done, and now this is the only cystic duct. After that, here we are using very simple, this is the Mishra's knot with the Vandarkar knot pusher, and just like appendix, you can go to the base and you can tie. One of the biggest advantage of the knot is that it will not take the lateral clipping of the CBD, because by default it will slip to the junction. I always tell the example that just like if you will put a tie on your shoulder, by default it will slip to your neck. So, this is the first knot, and knots are either exactly right or hopelessly wrong. So, you do not need to tie 2 or 3 knot. One Mishra's knot is enough, more than enough, and this is second knot towards the gallbladder. So, both the knot is applied, and after that with the harmonic we are cutting here in between. You can see this is harmonic which is cutting in between, and you should take care that tip of the harmonic should not touch the knot, and a good dumbbell is formed and it is cut, and after that you will remove it through the 10 mm epigastric port. Now, this retractor, lever retractor, we will pull it out, and after that fundus also is taken out, and because this is a very young, so we have not used any endo bag. However, if you want, you can use endo bag. The bile is sucked, and with the ovum forceps a stone is crushed and it is removed, and there is hardly 2-3 ml, maximum 5 ml blood. So, this is blood is sucked from Morrison's pouch, and the surgery is over. So, thank you very much for watching this video. Have a nice day.